topic for the next session is Right Iliac Fossa Mass, which will be presented by Dr. Ranjit Kumar and Dr. Balaji from Tirunelveli Government Medical College.
A 71-year-old female patient who is a homemaker hailing from Tenkasi admitted with the chief complaints of abdomen pain for the past 15 days. History of presenting illness. The patient was admitted with complaints of abdomen pain for the past 15 days, which was insidious in onset, confined to the right lower quadrant, dull aching, which increased on intensity for the past 4 days, continuous, non-radiating, no aggravating factors, relieved by analgesics. History of loss of appetite present. History of significant weight loss present. No history of altered bowel habits. History of easy fatigability for household works, but she is able to do her daily personal activity. No history of melena. No history of nausea and vomiting. No history of fever. No history of hematochezia. No history of abdomen distension. No history of cough with expectoration. No history of jaundice. No history of any other swellings in the body. Past history. Not a known case of type 2 diabetes mellitus, systemic hypertension, cardiac disease, bronchial asthma and pulmonary tuberculosis. Personal history, loss of appetite present, she consumes non-vegetarian diet, no history of altered bowel habits, she is a non-alcoholic and non-smoker, no history of sleep disturbances. Obstetric history, P3L3, normal vaginal delivery, attained menopause 30 years back. Familial history, no history of colorectal, breast, ovary, stomach, pancreatic malignancy in family members, no history of TB contact in the family. Summary, a 71-year-old female patient with complaints of abdomen pain, confined to the right lower quadrant, dull aching, continuous pain with loss of appetite and weight loss, with easy fatigability, no history of fever, with no comorbidities, with no history of TB contact, probably medical etiology.
So can you go to the first slide, please? (71-years-old female) complains only for just 15 days. Okay. What do you expect?
With a short duration of pain, we can expect a appendicular mass for this patient. Usually with a history of fever followed by patient can develop mass within 2 to 3 days.
Okay. So, but in your summary that you have told us, malignancy.
Yes,
why?
Considering the age of the patient with loss of appetite and the significant loss of weight and easy fatigability due to pallor established in clinical examination, so I like to confirm it's a malignant.
So the total complaint duration is 15 days. In that 15 days, there is loss of weight.
No, sir, for the past 6 months.
So the loss of weight dates back to 6 months.
Yes, sir.
Okay. It all started 6 months ago or just 15 days
The
ago?
patient has only history of loss of weight for the past 6 months, sir, but she is having pain only for 15 days, sir. Aggravated for 4 days.
Okay, right. And any other pointing factors?
No history of altered bowel habits, nothing, sir. Only history of loss of weight, loss of appetite and easy fatigability, sir.
Okay, 71-years-old female.
Yes,
Are right lower quadrant pain, right? So what are the differential diagnoses you want to have in your mind?
Tube ovarian mass, ileocecal
Tubo-ovarian mass in a 71-year-old female.
Malignancy, ovarian malignancy.
Okay.
Then hyperplastic tuberculosis.
Ileocecal tuberculosis. Okay.
Appendicular mass, 15 days.
Appendicular mass. Okay. Then
Crohn's disease.
Crohn's. So, pertaining to in the age 15 days history.
If it's going to be a malignant etiology, what do you think of the reason for pain? What is the explanation for the pain for the last 15 days?
Compressing the nearby structures, invasion of nerve compression or invasion can be due to necrosis, sudden hemorrhage.
Bit louder.
Due to tumor necrosis or due to hemorrhage, due to neural compression of the nearby structures.
So you mean to say that a malignancy which has gone for some complication, like it is either infiltrating into the surrounding structures, bled, or it has gone for necrosis.
Yes.
So what is the common thing which can happen in a malignancy, in a colonic malignancy?
Infiltration into ureter.
Ureter. You don't have any complaints relating to the urological system? It could be a case of a pericolic abscess. The patient can perforate and she can go for necrosis, perforate, and she could have developed a pericolic abscess. That could be one reason for a pain in a case of a long-standing malignancy. But you're not sure whether it's a malignancy. A 71-year-old female, is an appendicular mass common?
Appendicular mass common in engaged.
Why?
Due to localization with the momentum that's well developed in
Keep your mic closer. Let them also hear.
the momentum localization will be well developed in young adults while comparing to the females.
No, that
Old
is only
age.
for localization. So it belongs to a group of lymphoid organs. So it goes for atrophy, and usually appendicular pathology is very uncommon in older people, right? So it's more likely to, considering the age alone, it seems to be more in favor of a malignancy. Apart from that, this pain, 15 days pain, we're not sure of what it is. Okay. Go to the next slide. I'm moving. So what are the other positive histories you have in this patient?
History
Patient is having a 15 days pain, abdominal pain, lower right lower quadrant. Your patient has got a loss of appetite for 6 months. And what else do you have?
loss of appetite, loss of weight, and easy fatigability, sir.
Easy fatigability. Right. What do you think would be the reason for the easy fatigability? Anemia.
Yes.
Why? Why is the patient might have anemia in this?
In case of any colonic malignancies, there can be hematochezia, occult loss of blood, which can cause anemia in the patient, which can lead to easy fatigability.
Okay.
What about our bowel habits?
All habits normal, sir.
Normal.
Normal.
Okay. When do you expect abnormality?
Abnormality in case of mostly in case of left-sided colonic malignancies, where there can be annular obstruction, which can cause spurious diarrhea for this patient.
Okay. What happens in the right side lesion?
Right-sided lesion usually presents with mass, can be spurious diarrhea won't be it's a proliferative growth, not annular involvement only seen in case of left-sided growth, not in case of right-sided growth. And the diameter is also more in case of right-sided.
Which has got a better prognosis?
Left-sided colonic malignancies has better prognosis.
Why?
Because it earlier presenting with obstruction due to the obstruction, so it has better prognosis.
And also stricturous growth. It's not a proliferative growth. It's a stricturous growth and presence. You detect it early. Chance of detecting it early, right?
Yes.
Okay. Then.
Okay. Move on to the
Why
general
did you ask
examination.
about melena for this patient?
Associated upper G, associated synchronous malignancies which can cause upper G. Any polyps
You
can
mean
be.
something like a polyposis involving the upper GA also?
Yes, sir.
Okay.
Common metastasis to the liver producing jaundice, sir.
Pardon?
Metastasis to the liver in case of a colonic malignancy producing jaundice.
Anything else?
Pertaining to RIF, sir. Pertaining to RIF mass.
Okay. Move on to the next slide. Past history. Yes.
No significant past history. No history of KUMAR.
Regarding RIF, what will be the significant past history?
TB, sir.
Tuberculosis, okay. Then your diagnosis was malignancy.
Yes, sir.
Regarding malignancy? Yeah.
In case of ILIAC, is it necessary to have a history of pulmonary
No, sir.
tuberculosis?
Hyperplastic type is mainly primary GIT TB. Only ulcerative type only needs a history of PVTB, sir.
So which is surgically more important for us? Ulcerative type or hyperplastic type?
Hyperplastic type, sir.
Why?
Because it can cause obstruct the lumen and can be
One which causes the right iliac fossa mass, right? Ulcerative doesn't produce a...
Past history, any other surgeries in the past?
No history of surgeries in the past, sir.
No, I'm asking. Any previous surgeries?
this patient no
Not this patient.
significant is recent history of surgery for actinomycosis.
Recent history of surgery
Any open surgeries,
for
so any other procedures can lead to
pertaining to colonic malignancy. Right and left we are doing one surgery now. What is that?
appendix.
What is appendix? Next. General surgeons trivial, still there is one surgery. What is that?
History of appendectomy related to actinomycosis.
What is the long-term complication of lap poly?
Colonic malignancies. Post cholecystectomy status.
How many years later?
20.
15 years. Okay, right. Personal history.
Loss of appetite presence. She consumes non-vegetarian diet. No history of altered bowel habits. Non-alcoholic and non-smoker. No history of sleep disturbances. Family history. No history of colorectal, breast, ovary, stomach, pancreatic malignancy in family members. No history of TB contact in the family.
General examination. The only pale present, sir. Radiation is good, fair. ECOG score 2. Vitals stable. There is blood pressure 180 per mmHg, pulse rate 70 per minute, SpO2 normal, respiratory 18 per minute. Systemic examination of abdomen. After obtaining consent from the patient was made to lie in the supine position comfortably and adequately exposed and exposed under adequate light. Inspection, abdomen flat, complication midline and inverted, all quadrants moves proportionally with respiration. No obvious fullness noted. This is no obvious fullness noted. Click a picture. Skin over the abdomen, no signs, scars or dilated veins. No visible peristalsis per intestinal, gastric peristalsis per intestinal peristalsis. Renal angle, no fullness noted. Hernia orifice, normal. No cough pulse seen. Left supraclavicular fossa, no fullness noted. Palpation, no local rise of temperature.
What is the significance of this renal angle fullness for this patient? Is it for completion sake or are you looking for something else?
Completion.
Completion.
For abdomen examination. Mass of size 5 x 4 cm over the right iliac mass with well defined borders, surface irregular, hard in consistency, which is non tender, is mobile, lower palpable. Plane of the swelling is intraperitoneal, probably arising from the cecum. No other mass palpable, no organomegalies, liver span 13 cm, left supraclavicular fossa. Percussion, there is impaired resonance over the mass, other coronal resonance, no organomegaly, no shifting dullness, auscultation, bowel sounds heard. Other system examination, normal, RS normal blood sounds heard, CNS no focal noise, CVS S1 S2 heard. Summary, a 71-year-old female patient with complaints of abdomen pain for 15 days, with increased intensity for past 4 days, with loss of appetite and loss of weight, with easy fatigability, with no comorbidities. With present with mass which palpable in the right iliac fossa, just hard in consistency, lower border palpable, and impaired resonance with no organomegaly, probably arising from the cecum.
Can you move to the next one? So explain the palpatory finding. Describe. There's a
It's a mass in the right iliac fossa.
Okay.
Which is a 5 cross 4 centimeter.
Okay.
Which is well defined regular irregular surface. Which is
Regular, irregular.
Sorry.
Regular.
Irregular, sir.
Okay.
Having a sensi is irregular. Lower border palpable. Which is mobile, non-tender.
Okay, the patient is gives history of pain, but it is non-tender.
Yes, sir.
Okay. And what is that mobility? It is mobile, you have told, right? Okay.
There is a mild mobility.
Restricted. Cecal will be immobile, but this patient
CME is mobile or fixed?
fixed.
Mostly it is a fixed.
Fixed, sir.
Okay.
There's some
Mild
variations of peritoneal coverings can be sometimes mobile.
It's restricted mobility.
So appendicular mass will be mobile or immobile?
It's mobile.
Appendicular mass is mobile. Inflammatory mass,
Implement is immobile.
what will be the consistency?
It's a firm in consistency. Firm.
Here it is
Hard
Hard
and
and
consistent.
hard in consistency and it is mobile and it is non-tender.
Yes.
Okay. I say it is ileocecal tuberculosis.
Ileocecal tuberculosis, in case of hyperplastic type, it will be pulled up and be lightly at a higher level, not in
It will not be present in the
RA.
RF. Okay. Right.
First, ileocecal tuberculosis, carcinoma cecum. Carcinoma cecum.
Appendicular mass.
Appendicular mass.
Hyperplastic tuberculosis and CA-cecum. Actinomycosis, ileoceous abscess,
Ileoceous abscess.
then any retroperitoneal tumors, lymphomas, and iliac. Old age of the patient with the pallor, easy fatigability. Appendicular mass common in case of young age, but not in old, not very common in old age. So I would like to say it is CA-cecum. Then Murphy's triad.
Symptom.
Migratory pain, fever, nausea or vomiting.
So one symptom which should be always present in a case of appendicitis or appendicular mass is
Nausea.
anorexia, not nausea. It should be anorexia. Patient should have loss of appetite. Book says that without that you cannot diagnose a case of appendicitis. So this patient has got a loss of appetite, right?
Yes.
Patient has also got a mass. Patient has also got a pain. Why do you say it is not an inflammatory mass? What is against appendicular mass in this patient?
Hard in consistency and anemia.
From the history,
Old age.
apart from that,
No history of
Fever.
yeah, the patient doesn't have any signs of inflammation, doesn't have fever, doesn't have any pain except for the last 4 days, right?
Yes.
But still, it can be a case of appendicular mass. We cannot rule out appendicular mass in this patient. Right? Okay, what's against ileocecal tuberculosis?
Location.
Okay, it's, swelling is right in the right iliac fossa. So you mean to say it's not pulled up? Okay, right, fine. Then
It will be firm and consistency.
Okay.
And fever, night sweats, loss of fever, night sweats.
No history of any contacts.
Okay. So the only thing in favor of a malignancy is the age group, loss of appetite, loss of weight, and anemia, pallor.
Yes.
Okay, how do you proceed with this patient?
Uh,
We still cannot rule out appendicular mass and a CECM. We need to look into that. How do you proceed?
To confirm the origin of the mass, proceed USG abdomen pelvis to see where the origin of the mass. Depending on that, if it is a cecum, I will.
Now, what will the ultrasound tell you?
ultrasound whether the location of the mass.
Okay, the location is the right upper, right lower quadrant.
Circumferential
Some
wall, there is circumferential wall
thickening
thickening is
of
there,
the-
hypoic occlusion is there, and status of the nodes. If it is a malignancy, ascites, peritoneal deposits, liver secondaries,
Peritoneal deposits can be picked up by ultrasound.
CECT. If large peritoneal
We are
deposits,
talking about ultrasound. Okay.
large peritoneal deposits,
Okay.
then any secondaries in the liver can be picked up by ultrasound ascites.
Okay. So the ultrasound says there's a mass in the right iliac fossa. There's a thickened bowel. Is that? Then what do you do next?
CECT abdomen with and colonoscopy.
Go one by one. You want to do a CECT abdomen, right? So what better thing is going to show in a CECT than your ultrasonogram?
If it is a malignancy, if there is any local infiltration to the underlying structures and liver secondaries and peritoneal deposits will be better seen in CECT abdomen. And extent of the lesion, all those things will be better delineated in CECT than
Thickening of the wall, any irregularities in the intraluminary, nodal status.
Okay, fine. Then,
Can I pick up ileocecal tuberculosis? CECT?
yes. Yes. Yes.
Okay.
so what is the ideal investigation you are supposed to do to make a correct diagnosis?
Colonoscopy.
You want to do a colonoscopy and do a biopsy,
Yes, sir.
right?
Yes, sir.
Okay, then biopsy comes as a adenocarcinoma of the cecum,
Metastatic work.
right? What do you do?
CT chest.
And
And tumor markers.
what tumor markers?
Carcinoma. C.
Okay. Right, C is elevated. Colonoscopy comes as adenocarcinoma of the cecum. What do you do next?
I'll optimize the patient, plan for surgery, correct the anemia, do the routine investigation and correct all the basic parameters, and do post-op surgery and do laparotomy and assess for any meds.
Metastasis.
Would you like to do a diagnostic laparoscopy for this patient?
Even though metastasis is not a contraindication for resection.
We can do.
Metastasis
can
is
do,
not a
sir, but-
contraindication for resection.
So diagnostic laparoscopy is the investigation which can show you what it is, right?
Yes.
It can tell you. Colonoscopy and diagnostic laparoscopy is to be done if you take up the patient. It can show you undetected peritoneal metastasis in a case of cecum. That should be done. So once you have done that, then you can proceed with your surgery, either laparoscopically or by open conventional method. So if you are going to do a surgery, what do you do for a case of carcinoma cecum?
Right hemicolectomy.
Padamba?
Right hemicolectomy.
Right hemicolectomy. What is the structures which are removed in a right hemicolectomy?
Distal 10 centimeter of ileum, cecum, appendix, ascending colon, and proximal one third of transverse colon, and by ligating left branch of middle colic, right branch of middle colic artery.
And the meson along with
So what is the extended right hemicolectomy?
The origin of the middle colic artery should be ligated. Both left and right branch should be ligated, and the supplying bone
Right.
should be removed.
Good. So why do you want to remove the 10 centimeters of ileum?
Ileocolic artery supplying the distal 10 centimeter of ileum, so we are ligating the ileocolic artery and
Okay, fine.
What is the anastomosis you do?
end to side anastomosis, ileotransverse anastomosis.
End to side. Why end to side?
But leak chances will be less in
Why not end to end?
Stasis will be there in case of.
End to end.
So we can do, sir. But giving Chittle's cut, we can do.
So you'll do by open method, hands on or stapless? Which do you prefer?
Both have equal.
Okay, you got stapless. What anastomosis you will do?
Side to side.
Side to side. Okay. Why not end to end? Lumen discrepancy and interception are common. Okay. Right. And what is the role of chemotherapy?
Post-adjuvant chemotherapy we can give, so based upon if the nodes are positive, lymphocyte invasion is there, and T4 size, T4 stage, and if it is a poorly differentiated adenocarcinoma, signet cell carcinoma, we can give chemotherapy for this patient.
What regime?
Folfox.
While doing a right hemicolectomy, what are the structures you have to be careful about?
Ureter, gonadal vessels, and duodenum.
And
Duodenum.
Suppose the biopsy, the colonoscopy biopsy comes as lymphoma. How do you proceed? Assume it is a cecal lymphoma, how do you proceed?
Assume this patient is having no obstructive symptoms, so that we can go for only chemotherapy. Regime.
You need to stage the disease, no?
Yes.
Staging
For
of
staging, for it is lymphoma, we can do PET CT to for staging. Sir.
when will you do chemotherapy? When will you do surgery for a patient with cecal lymphoma?
Any obstruction, we can do surgery. Any complication of the preparation.
Otherwise, no surgery. What is the histopathology in a non-Hodgkin's lymphoma of the cecum? NHL. What is the histopathology?
Anarbor.
Pardon? The origin of the tumor is from which cells?
B cell.
B cells. Good. So it's the tumor gets origin from the B cells, and it's a non-Hodgkin's type of lymphoma. It's extranodal lymphoma. So they'll have extensive nodes of the mesocolon, and we have to stage the disease. Then we need to do a chemotherapy, and then we need to resect the lesion.
If it comes as appendicular mass, what will you do?
Arsenal surrender regime. Conservative treatment. Admit the patient, IV antibiotics, analgesics, and Riles tube aspiration, and vitals monitoring, respiratory rate and temperature of the patient, IV antibiotics, analgesics for the patient, and marking the mass, and we have to check whether there is increasing size of the mass. The mass size of the mass is increasing, and the patient having any symptoms like fever, increasing temperature, tachycardia, tachypnea, and all those things. Conservative treatment should be discarded, and we have to operate the patient. We have to drain the abscess.
Any other scoring system apart from that Alberto scoring?
Adult appendicitis score.
Okay, it comes as appendicular abscess. What are you going to do?
You have to drain the abscess. Appendicectomy.
Any size of abscess you will drain?
Then greater than 3 centimeter abscess or abscess greater than 3 centimeter abscess we should drain. Less than 3 centimeter collection we can treat conservatively.
Okay. How will you drain?
Extraperitoneal draining.
Any other methods?
USG guided.
What is the problem of intraperitoneal drainage? Why don't you do an intraperitoneal drainage? What is the issue? You are telling extraperitoneal drainage of appendicular abscess. Why don't you do intraperitoneal drainage?
It is that's ileocholic abscess. We have how to go intraperitoneal drainage. It is like a pelvic or a petrosal abscess, we can go for extraperitoneal lavage.
The small abscesses, you can do a percutaneous ultrasound guided aspiration. That itself, once you aspirate the pus, the inflammation can subside, and with the antibiotics you will be able to manage, tide over the crisis and take up the patient for an interval appendectomy. The abscess is quite big and it's confined to the right iliac fossa, it is walled off, then you can do an extraperitoneal drainage. But laparoscopically we also do an internal drainage also, no harm. You can just put a drainage and come out, all that can happen. Anything can be done now, right? Fine. So you find, you open a case of a CSC, plan for a hemicolectomy. You are not able to do a resection. You find that it's infiltrating, it's intraoperatively you find it's infiltrating. What do you do? The patient is presenting to you with an obstruction. What do you do?
Not receptor, we can go for iliotransverse anastomosis. It's difficult to resect.
Yeah.
You can go for iliotransverse anastomosis.
Okay, you can go and do an iliotransverse anastomosis. What are the complications of doing iliotransverse anastomosis?
The patient can go for closed loop obstruction like that.
Yeah, you can go for a closed loop obstruction.
And perforation.
So, pardon?
And perforation.
And perforation, right. So in order to avoid, you want to avoid a closed loop obstruction or the patient is unfit for a iliotransverse anastomosis, then what do you do?
Ileostomy.
Yeah, you can do an diverting ileostomy can be done. Right, fine.
Stenting.
Right, you have done an open procedure. You have done an open the abdomen or a laparoscopy. You find that now you can do a iliotransverse or you can go for a ileostomy, right? Okay. If there is a case of ileocecal tuberculosis, what do you do?
ATT.
You start the patient on ATT.
Yes.
Fine. Then, would you like to add anything else to the ATT?
Sir?
Would you like to add anything else to the ATT? Any drug else you want to add? So once you start an ATT, this can go for a stricturous healing process, right? So not to avoid that, you're always supposed to add some steroids for this. You combine it with an ATT. Otherwise, the patient will end up in a complication of this thing. Right.
When you done a laparoscopy, as you told, or you have planned for open surgery, you're thinking it's a right hemicolectomy you are planning, and you found a extensive mucinous deposits in the peritoneal cavity. What will you think? How do you proceed?
Myxomoperitoneal.
So, how do you proceed?
Particular neoplasm.
Yeah.
Hypec.
The etiology may be from the appendix. So, what will you do?
Hypec can be.
Hyper?
Hyperthermic intraperitoneal chemotherapy can be given.
Then
Then hemicolectomy.
yes, we have to go for a right hemicolectomy combined with the hyperthermic intraperitoneal chemotherapy and chemotherapy.
When do you suspect Crohn's?
Symptom wise, sir. Abdomen pain, diarrhea, hematochezia, anemia,
Along with that, any other finding the patient will have?
complications,
The
extra
patient
intestinal manifestations of
patient-
Crohn's.
patient
Pyoderma
may present
gangrenosum.
with lump, and in the colonoscopy there will be a more involvement of the rectum, and the
Lesions.
skip lesions will be there.
Yes.
And
And
at least
Tromas,
upper
fissures.
stitches.
fissures, fistulas,
Yeah.
and extraintestinal manifestation of Crohn's will be also.
What are the premalignant lesions of carcinoma colon? CSE?
FAP.
FAP. What is FAP?
Familial adenomatous polyposis.
It's an autosomal dominant disease caused due to the APC gene mutation. It is usually characterized by multiple polyps all over the over in the large bowel and small bowel and in upper GI also. High 95 to 100% of chance of converting into malignancies. They are usually diagnosed less than 30 years of age.
What is the common presentation of the FAP?
Interception
What age will it usually present?
less than 30 years of age.
Common presentation is asymptomatic. Most of the time they present with malignancy. So suppose a patient is coming to you with a FAP with malignancy, what will you do? FAP with malignancy. Suppose
We can do a either we can do a proctocolectomy with iliorectal anastomosis with the AL pouch, or we can do a subtotal colectomy with iliorectal anastomosis.
good.
That was a good presentation.
Thank you, sir.
Thank you.
All the best.
Thank you, sir.
Thank you.